Good afternoon, ladies and gentlemen who have joined us on this Dr. Fundi channel. Today, it's one of our Salute Sunday show. As you know, when we have a Salute Sunday, we invite a guest, we invite somebody who is making great things in their chosen profession. So today, we have invited a special guest, a colleague, a friend, somebody I've known for more than 30 years. We were together at medical school in the 80s, and he's doing great things, as part of the people who are shaping the health or the healthcare system of South Africa. So my special guest is Dr. Ntuthuko Bhengu. Now, Ntuthuko, if I understand the meaning of the name, Ntuthuko, I think it's progress. It's it progress? Please correct me, Ntuthuko.
It is the direct translation which led to my nickname as well.
Okay. All right. So I'll tell you a little bit about Dr. Bhengu before we then welcome him formally and get on with our conversation today. So Dr. Bhengu, he is a qualified medical doctor who obtained his MPCHP degree from the University of Natal. That was before it was changed to be UKZN. He went further and studied anesthetics from the College of Medicine of South Africa. He was not done. He continued and studied for the Masters in Business Administration from Wales, Cardiff, and also added Masters in Public Health, specializing in healthcare management from Harvard University. And that Harvard degree gave him an in-depth understanding of the global health policy and management of corporations in pharmaceutical, biotechnology, hospital, health insurance sector. So basically, it gave him a solid grounding across, the continuum of healthcare. And his career spans over 20 years. And he's operated as a clinician both here in South Africa and also in England. And he's also been a senior executive within the South African healthcare sector. He also has participated as an invited speaker at the African Business Conferences for the at the Imperial College, UK 2016. Also at Harvard Business Schools, USA in 2017. He's delivered keynote addresses at the Africa Directors Program offered by the Stellenbosch and INSEAD Business Schools. That was in 2017. In March 2018, Dr. Bhengu was invited by Harvard Global Health Institute to participate as a speaker at the London workshop on counterfeit and substandard medicines. And the theme of that conference was medicines that lie, a deadly public health crisis. He's also a fellow of the Africa Leadership Initiative. So, Nolus, welcome.
Yes. Thanks, Pele. Thank you very much. And I'd just like to greet your viewers and just to thank you for the opportunity. I'm highly honored to be to occupy the hot seat, your hot seat Sunday.
Yes, no. It's a lukewarm seat. It's a lukewarm seat. Yeah. So, Doc, we are going to go through just quickly through who is Ntuthuko? Where does he come from? What kind of childhood did he have?
Yeah, Ntuthuko Bhengu is 53 years old. I was born in Ladysmith, and the last of a family of 10. Yes, I'm number 10. Lat Lameki.
I was about to say that.
Yeah, the brother I come after, Zulu, is 5 years older than me.
Yeah.
And my eldest brother got married a few months before I was born. So,
sure.
So I really was a Lat Lameki.
No, you definitely are a Lat Lameki, and in such a big family, I mean, and you being the last born, there is this view that's, depending on one's position in the family,
Yes.
your character and how you just, look at life differs. People believe if you are a last born, you tend to be somebody who's spoiled in many ways, somebody who can be manipulative, somebody, but I don't know you as having any of those characteristics, as a last born. So I think that generalization doesn't work with you.
Yeah, there may be an explanation, and that could very simply be that I left home early to go and study to start my lower primary education in Pietermaritzburg, where I lived with the principal at that school. This is Nichols in Edendale, and the reason is because locally I was deemed to be too young, and they wouldn't accept me to start sub A. So I was shipped off, and I suppose my mother always said that probably helped me in being independent as it were.
I'm seeing a similarity there, Doc. You just reminded me. Those days to start sub A, you had to do this test.
I couldn't reach.
Yes, if your hand cannot reach the ear, you were not ready to start school. Exactly. And I failed that test. And my parents, also, they made me, at the age of 4 to go and stay with the principal. So I'm seeing some commonality there.
Exactly that. I couldn't reach. And fortunately, in Pietermaritzburg, they said, the parents know best. If you think your child is ready, then they were fine. But there's also the backup. If by Easter you were seen to be struggling, if you're young, then you'd be going to the nearby crash. Yeah. And I didn't struggle much, so I stayed and completed.
Yeah. Okay, so Doc, you came from this big family of 10, with a big age difference between the firstborn in your family and yourself, So growing up in that family, just one or two things that would say you learned or, they were instilled in you in that family that are still helping you as you navigate life today.
Yes. Yeah, I say I'm very fortunate. I had 12 parents in the sense that precisely because I was that much younger, it's obviously my father and my mother, but every one of 11 parents. See, my arithmetic is killing me. No, every one of my 9 siblings contributed to me in very different ways, but all positive.
Yes.
So that instilled, we were fortunate. We come from a family that prized education. Parents instilled the principles of integrity at a very young age.
Yeah.
And we just grew up that way, and I carry that today. I interact with my siblings, but that still comes through in all I try to do. Yeah.
I mean, you've just mentioned now the issue of integrity. And when I was writing a promotion post yesterday, I actually said, you're one of the ethical leaders that we have in this country. And I can see the link for sure. And I've known you for so long. I've never been in a situation where there's any question mark around your ethics and, and integrity. So, yeah. And you can see some of these things that we display in later age are actually coming from how we were brought up, as youngsters, Yeah. So
no, that's kind of you. I appreciate it. Those kind of words, but we try. No one's perfect, but we try.
No. Obviously, yeah, obviously, but for the period I've known you, I can vouch for that. So education was this big thing in your family. Why was it? Because maybe one of your parents was an educator, or
Yes. No. Yes. But look, neither of my parents reached a university, but my mother did teach. My father was an entrepreneur.
Yes.
But I suppose commitment to education shows that, in the sense that my father actually got his matric, I think, at the same time as one of my sisters. I think it's someone who occupies position number 6 at home.
Yeah.
Because he felt this was a gap in terms of what was important. So through his appet or whatever, he still felt the need to get the matric.
Yeah, no, beautiful. I always like to hear stories like that, where people, they when they look at age is no barrier. If they want to add knowledge and skills, whatever the age, they must go and do that. I mean, we had here hot sticks, Mabuse.
Yes,
about less than 10 years ago, he actually went and finished matric.
Yes.
So to say age should never be a barrier if somebody wants to continue and add. All right, so growing up, Doc, what did you want to be? We've got that thing when we are playing, with the other kids out there, and we play certain roles and say, hey, no, I want to be a policeman. I want to be a doctor. So for you, did you have any, idea of what you wanted to do at that age?
Yeah, look, I suppose we grew up when we were fortunate in the sense that our options were pretty much limited. If you did well at school, you'd be a teacher, a nurse, a policeman, a doctor. So certainly the wanting to be a doctor was one of my early ambitions, as it were, to the extent that even when I was at high school, I got a scholarship to go to Hilton for what was then called Form 6. And I would then go and do fully paid degrees in CA or engineering in Cape Town, I think.
Yeah.
But my mind was clearly made up. That's what I wanted to do, yes.
Beautiful. You're the opposite of my brother, Umtetu, because he also got a scholarship from TEPA. TEPA was like a recruitment agency for the mines to go into medicine. Yes. But, his mind was made up that he wants to do engineering. And for you, it's the opposite. You had made up your mind that medicine it will be, and that's what happened. Lovely. So, any highlights in your high school years, Doc?
Yeah, on a lighter note, because I was the last one, I went to Ntuthuko College, which was a boarding school.
Adams College.
When I had 2 sisters and a brother.
Yes.
Or 2 brothers who were there before.
Hey, Doc, your picture is just frozen there a bit. Dr. Bhengu?
Right. I think we have thunderstorm now. Can you hear me though?
No, I can hear you now. You were gone a bit, but it's fine. We can continue. Can
you hear me? I can hear you.
Yeah. Okay. Yeah. So you say you went to Amanzimtoti. Is that Adams College, just south of Durban? Doc? All right. We still continuing with our conversation with Dr. Ntuthuko Bhengu, most times we look at the people and what they have achieved. We don't know what actually informed, their growing up. So when I do these interviews, I always start with, 5-10 minutes of just getting to know the person, the kind of family that they come from, also just what kind of values that were instilled in them as they were growing up. So at this point, Dr. Bhengu is telling us that he went to Amanzimtoti, that's south of Durban. There used to be a very famous college there called Adams College, which was, I think, a missionary school at some point. So, Dr. Bhengu, can you hear me? Okay, I can see you. Yeah,
you can see me. Okay,
I can see you and I can hear you. So, you went to Toti. Can you just tell me a little bit about your being at Toti?
Yeah, it was an eye-opener because, of course, this was now outside of Durban. And I did very well academically. I think in matric, I got the DAX for the highest marks.
Yes.
And over and above that, I also formed quite a lot of good relationships coming out.
This.
Can you hear me?
Yeah, I can hear you. Yes, you formed very good relations with people that went to school with you at the time.
Yes. And and then from there, of course, then it was time to go to university.
Yeah.
And I knew it was going to be medicine. The question was whether it would be Natal or Vets.
Yeah.
Those are the options that I had.
Yeah.
And I actually looked at the two universities in the sense that I attended the summer school during matric, Natal, and in January, just before the academic year started at Wits, they had, Natal was the winter school. It was the summer school at Wits at the beginning of the year. And I was based in Parktown at EOH.
Yeah.
Yeah, and so then it was off to university. I chose KZN, I think, mainly because on social level, I mean, Wits was quite a bit, it seemed, I seemed isolated, as it were.
Yeah,
obviously, the KZN was my home province, so I knew a lot of people from high school and family.
KZN offered a better support system than you would have had you gone to Wits. All right, so you are this Latlameki who dreamed to become, a medical doctor or to study towards being a medical doctor. Eventually, you get those excellent results. You are admitted to University of Natal to do medicine. So just your sense of that transition and what did it mean to the family?
Yeah, it really meant a lot for my family, especially my father.
Yeah.
And so it was very important. I mean, one of the funnier parts of this is that when I first went home in first year, during Easter, two things happened. Somebody knocked at the door saying someone was in labor 2 houses down. And so thankfully, Bhengu has a son now who's studying to be a doctor. As you can imagine, that would have been a disaster. Fortunately, there was someone who was qualified in the family and the nursing side, so that was help. But coming from a small town, if you are studying medicine, almost everybody knows that you are. Especially because the family was fairly well known where we were. On being in business locally.
Yeah, wow, wow, wow. I mean, if they knew that the only thing you could do at the time was to operate on rats and the dog and not much.
Yes,
The actual training in medicine had not even started at the
not
time.
at all, not at all.
Yeah, no, beautiful. But that just tells you though how that society where you came from was supportive of the direction that you were taking, and they were
Yes,
actually looking forward to you, graduating and coming to add value,
yes,
in the community. All right.
indeed.
So when you got to med school, obviously, and me and you, that's where we started to know each other. And you did your medicine. We happened to stay at the same,
Yes.
what do you call it now?
President.
Residence, which was, we're at Alan Taylor Residence next to the Mobile Refinery there in Wentworth, and we stayed at the same block, which was
Yes.
called Mosquitoville.
Mosquitoville, yes.
Yes, I stayed on one end of the block and you stayed at the other end of the block, but we stayed in the
Yes.
same block,
Exactly. The popular Mosquitoville.
Yes, exactly. So we are squirtles. And I guess when I looked, I thought, where did this name come from? And I remember there was a little stream just behind, and I think it was because of the mosquitoes that used to come from that stream that would terrorize us, especially, in summer,
Yes.
Yeah.
Yes.
Okay, Doc. So any highlights from your time at medical school? I know one highlight is the fact that that's where you met your wife,
Yes.
Dr. Tobeka Poltina.
Yes.
We'll talk about that highlight, but just other highlights.
Yes. No, certainly that's that's one of them, the important one. Others were basically, I was thrown in at the deep end. I was class representative for first year when we started, and I think two more times during the course, the 6-year degree. And I think this is where I would like to believe that my leadership skills were honed in a very difficult environment as a student, where we all equals. But it certainly was a highlight. A lot, I believe, I achieved during that time. I managed to go through the course as required. But we believed at the time in working hard and playing hard.
Yes,
so
definitely.
We had a very healthy social life outside of studying, but when it was time to study, we certainly knew what we had to do. So yes, that was absolutely important, yes.
And here we're talking of Goombas. Alan Taylor Residence was known for having the best, parties, which we call Goombas, in Durban. So anyone was looking for fun.
Yes.
Would certainly get the fun, because weekends were for fun. During the week was for studying.
Yes. Yes.
Yeah. And then you guys, you moved, because we were the last group to be at Alan Taylor Residence. And then from 1990, you guys moved to the main campus. Yes. How was the social life there?
Yeah, the last 2 years we were at the new campus at Howard College. It was certainly a very different, but also very good environment, because what didn't change is that we were still students, yes, but there was far more integration I don't mean so much at racial level, because there were very few whites who still stayed where we were at Albert Luthuli Hospital. So it was still largely black, but the arrangement in terms of integration from a faculty perspective, integration from a gender perspective, as it was. One floor would be men and the floor above would be women, so it was highly integrated.
Yeah.
But also it was much easier. We didn't have to spend all of those hours traveling to school and back.
Yeah.
There was far more proximity to main libraries.
Yes.
Not far from the medical school down the road. It's certainly from the perspective of making the life of studying better that was certainly achieved. Certainly we did not, our lives, our health must have improved, having moved away from the fumes of the oil refinery.
Yeah.
But the vibe, the social vibe was not the same. It has to be said. There could only be one Alan Taylor residence. So that was the difference,
Okay, all right. Okay, Doc, let's move quickly because I want us to spend time on, your work life because, that's the part. So you finished your medicine, must have been in what, 1994?
No, 91.
Oh, 91. Why do I think, sorry.
No, 94 was, I had come back to do anesthetics.
Yes.
94 was the postgrad anesthetics qualification, yes.
Yes, all right. So you were the class behind Abobov. Yes, Abobov, they qualified in 1990 and you then finished in 1991.
Yes.
All right, so you did your internship and then you went back and did anesthesia. What was the attraction for you to go and, there's this joke that the first person to perform anesthesia was actually God. When he made Adam to sleep and his rib was cut, from which, a companion was made. Yeah, so why anesthesia?
Yeah, look, the funny thing is that I grew to love anesthesia afterwards, but my choice to do anesthetics was really just a calculated one. For the simple reason that at that time I had decided that I wasn't going to be a clinician all my life.
Yeah.
And I chose anesthesia because it was and still remains the most portable, as I say it, most portable medical discipline. Possibly, if one excludes maybe psychiatry, if you like. And what do I mean by portable? I'm sorry about the thunderstorm here. I hope you can hear me. Yeah, what do I mean portable? I knew that I had a limited time in clinical medicine. Of course, I enjoyed it and I was doing extremely well academically, but it was portable from the sense that if you do not think you're going to stay in clinical medicine for too long, it's the right one. For the simple reason, it doesn't take long to build your practice. You really just go and negotiate with surgeons, get the disciplines that you want, a general surgeon and obstetrician and ophthalmologist. So you're building your business is really talking to other colleagues who are in surgical disciplines.
Yeah.
So it's unlike 3 or 4 years of building clientele.
Yeah.
But also, when you leave, it's also just as simple because then you negotiate, you indicate in about 3 months, I'll be winding down practice. And invariably, they look at you to try and find people who replace you. So that start and end is highly controllable. But even the perspective of really just being in clinical medicine, you really invest in a laptop and a stethoscope because you work in hospital, whether it's in theater, in ICU or casualty, you are in hospital and all your equipment is provided by the hospital. So it was quite portable and remains portable, as I say.
So if you have a qualification in that space, the barriers to entry are not as hectic as if, for example, one had become a radiologist, where, to set up a private practice as a radiologist, there's huge capital investments, that are required there. But I'm still interested though, what made you to think that I'm not going to stay long in clinical medicine, you know.
Yes. Look, first I must say that without a shadow of doubt, clinical medicine, I still regard it as really just the most important profession, because we're dealing with the most precious thing here, and that is life. I was fortunate in seeing how medicine work early. In Durban, I got an opportunity to shadow two of the leading general practitioners. Even right from the time I was late in my clinical years, over the weekend, I would go and work with Dr. Vuyo Mashalaba, the late Dr. Vuyo Mashalaba.
Yes, Mlas.
Mlas, yes. Mother to Ipileng.
Yes.
Yes, and Merafe,
Yes.
the three uncles there. So I worked with her, and I understood how general practice works.
Yeah.
And I learned a lot. And I think after qualifying, I worked with our colleague Gops, Dr.
Yes.
And Dr. Judy Dlamini, and Dr. Judy Dlamini as well. So I had very good exposure from very good people early on. But I think for me, I enjoyed the clinical part, but I always say that maybe it's because I grew up when I'm back from boarding school, I was expected to assist at home with business. So it means at the time when everyone was on holiday, I was working. As if in boarding school, one was playing, but that just wasn't the case. But so for me, how that affected is that when I looked at my career, I felt I just wanted the career where I would have the opportunity to travel.
Yes.
To go and travel to do work.
Yes.
And unfortunately, that's the part where medicine, I think, falls short.
Yeah.
Because simply you build a practice at this location. So every day, this is where you go. Your only options really is if you have an itinerant type of arrangement where you can have maybe 2 or 3 different places where you work from, or maybe then travel to conferences. But I'm not criticizing that. I'm just saying, for me, that was an interesting part.
The lifestyle that you had chosen for yourself was not aligned with the common journey of being a GP, because basically you can be 12 hours in that locality and yes, providing health in that locality with very little time to do anything else, including travel.
But it's not so different even as a specialist, because remember, even though I had done the postgraduate diploma, but it essentially was a specialist type practice in the sense that it's in hospital. So it's the same thing. You either have your rooms around the hospital, but again, it's the same environment that you go to. As I say, it's not criticism. It's really a question of what it is.
But I mean, there's nothing wrong. It's a choice. You had a certain lifestyle you wanted, and it's a choice, and you made a choice to say, I'm not going to be long. Because I think the other thing is that when we're at med school, we don't tend to understand the different options that are available to you in the healthcare continuum. And so what you're talking about was saying, look, I've got no issues about being in clinical medicine, and practicing. However, there are other areas within the continuum which actually I can add value, maybe not just at a locality level, maybe I can shape things at a national level, continental level, global level, you know, and actually make life better even for the colleagues who are in private practice.
Yeah, indeed. But even the move away from clinical practice was managed in the sense that I didn't just wake up one day and I left. One of the areas of interest was what I call the business of healthcare. I had explored sports medicine. I had explored sports medicine to the extent that I was part of the first South African Football Medical Association. And I used to also, in support of Dr. Phil Mahepa, sometimes go and be at the Kaiser Chiefs training sessions. But during the 1996 Africa Cup of Nations, I was the head of the doping controls for the Durban region. So that was when I thought my career was taking sports medicine direction. But in the end, I think it was too early. The two things I didn't quite like, for example, I think it was hard to see how I could make a living out of it, because it was, unless you were at a very good club, it was seen as, you know what, you're doing what you love anyway, and it's not like the remuneration.
They were not really willing to pay a professional for that work. And I was doing the same at
Mthatha Parks, And then there's the element of travel. If you were attached to a football club, at least every other week you are away from home. So in doing that analysis, I basically said, look, let me look what the business of healthcare has in store. But I think if I had stayed, I probably would have been a radiologist. I had also secured a post there with Dr. Tamim Ngoma in KZN. That would have been possibly what I would have liked to do.
But then, so anesthesia then, or anesthetics, took you to the UK. So it actually helped you to get to work in the National Health Service in the UK. Just tell us a little bit about that, and how that experience of working outside of South Africa in one of the most established healthcare systems in the world, how it contributed to the person you are today.
Even that came as really, I had decided that I wanted to go to the United States to study the business of healthcare and health policy. But I went to England really to raise funds. I wanted to earn pounds. So I went and spent 7 months working there. My base was Russell's Hall Hospital in West Midlands, just outside of Birmingham. I was placed there, and my wife and my child was even a year old, if not less, and he came over to join me. It was an eye-opening experience. I was based in an hospital, but when I wasn't working over weekends, I would sort of use the time to see the country. For example, I would say, well, this weekend I want to go and work in Manchester. Then I take a weekend call in Manchester. When I'm finished my call, I take the bus to see the city and visit the different soccer stadiums. So, but the National Health Service as itself, for me, it was properly impressive in seeing that all of the hospitals were very well managed. I'm sure there are always complaints, especially around long waiting lists, but there is no question that the system as a safety net works. You cannot be denied care simply because you don't afford it. They pay nothing at the point of service, but also not just being a healthcare professional. I was on the receiving end as someone who was visiting the country.
Yeah.
Soon after, as I said, my wife and my child, they arrived later.
Yeah.
But when they did, believe it or not, in the same week they arrived, I got a call from the local GP that according to our records from immigration, you have a young child in your home. We are going to send a nurse practitioner to come and assess the environment in which the child will be living.
Yeah.
But please do have a record of their vaccination history.
Yeah.
And indeed, she came, assessed, and made arrangements for the additional vaccinations that obviously there's slight differences in terms of timing in South Africa and UK. So all of that was sorted out.
Yeah.
So it's the prevention part of it. So I learned a lot in saying, you know, from a universal health coverage perspective, we can't go wrong. It's late in the day, but it's good that we are talking about it locally.
Yeah.
But as a system, every country should be striving to achieve that for its citizens.
Yeah. All right. We're going to come back to this because that's going to be the last part we're talking about, you know, the future of healthcare in South Africa, you know, the NHI as our own brand, you know, of a universal healthcare system. All right. So you were quite impressed by how the NHS in the UK functioned. How long did you stay in the UK, Doc?
I was 7 months because I arrived in Feb. That's when the company that arranged my locum placement. Yeah. I started beginning of February. Yeah. And I stopped when I had to go to Harvard when the academic year started in September.
Yeah.
So it was the 7 months of hard work, earning pounds, but really not having much of social life. But
yes, yeah. All right. So going to Harvard, was that then for the MPH?
Yes, because because I think at that point I had done the MBA, but at least now you do see a lot of MBA streams that deal with healthcare related issues. They almost went in existence. So I always felt it was excellent in giving me broad principles of business as MBAs are designed to do.
Yeah.
They say inch deep and mile wide.
Yeah.
Wide. But I wanted a very specific course for healthcare. And that's what I found, because the healthcare management stream meant that we did all the business courses, whether it's corporate finance, financial accounting, it's strategy, it's operations. All our case studies were based on healthcare, and healthcare being health insurance, management of health practice, hospitals, biotechnology, and pharmaceutical businesses. So, but over and above that, I could take a course from the Harvard Kennedy School of Government, where then I did global health policy, health economics, which then really gave me a comprehensive view of health policy, not just in the US, but also in low to middle income countries as well.
Yeah.
So, and then of course, the other courses that you couldn't get in an MBA, the biostatistics, the epidemiology, which is really now the public health angle. So it was the perfect structure for me for what I believed I wanted to achieve over a career of a lifetime.
Yeah. Okay. So, you know, I mean, what you just said now, the fact that, you know, there are general MBAs, which are very good, but if your mind is set up that you want to play in a specific space like healthcare, then there are areas where, you know, they are short, you know, and but I'm happy to see that there is a slight change nowadays. Gibbs has just come up now with a version that has got healthcare, an MBA in healthcare.
Yes.
Around the turn of the century, 99, 2000, there had been a program at Stellenbosch, but because of low enrollments, they killed it. Yes. You know, and the next best thing was then one to do programs with international universities, either distance programs or what, So I'm glad that those people are set, in playing within the healthcare space, because one of the challenges, as you know, Doc, one of the challenges in our healthcare system is around leadership and management. Yeah. There are many challenges, but leadership and management, we need a lot of clinicians to do the work, but also we need people to lead and manage the system. Yes. And there was this what I call it, resentment at times by medical colleagues that the people who lead and manage our space are either lawyers or people who've done, the commercial subjects and all of that. And so, and I mean, it hasn't really changed much. There's still very few people who have actually followed the direction of saying, I want to be in the business of healthcare. I want to be a competent leader, manager, in this space, so that the majority who are actually working, at coalface level, they can be able to work in a better environment, even better because the environment. Yes.
And the other part also, it used to be that the best doctor would then be assigned the hospital superintendent. Yeah. Which is, they may be familiar with the clinical issues, but clearly out of their depth from a management or leadership perspective.
Indeed.
But this is a global problem that I think only now, possibly because of the formal structuring and teaching in healthcare management, we are starting to see the potential to blend this. I mean, even in the United States, they were faced with the same problem at some of the largest hospitals. Because our lecturers were also out in industry, so we used to know and understand what's happening. But again, the clinicians were still very unhappy, and they used to refer to management as suits. as they are fancy, they're swanky, and they take decisions, but not the clinical side. But I think we've moved on from there. Yeah. But the challenge is that management of system obviously must be well-versed on general leadership and management issues. Because it is a complex place. Yes.
Okay, Doc. So you now have been exposed to the NHS in the UK. You now have gone through the program, the MPH program at Harvard, got exposure on matters of global health through what's that school? Is it what Chan, or is it a different one?
Yes. It's the School of Public Health and the Kennedy School of Government. Yes.
Okay. So you were now well-rounded, Doc. You've got the MBA that gave you breadth and depth on how to lead and manage. How to plan strategically. How do you, all the things. And now you've got depth in healthcare. In terms of the global picture, different systems from, the Cuba model, that has got some of the best outcomes, all right, to the neighbor, the US, with some of the worst outcomes.
And spend so much more.
Yes, and spending so much more, and all of that. Okay, so at what point then did you come back and say, all right, now I'm starting my own entity, Alchemy Health Technologies, which is a data management company? Or, just tell me a little bit now, you now got all of this knowledge, then the wisdom, and you're now saying, I am ready to help solve problems.
Yeah, I'm laughing because the gap between that and alchemy is so wide. It's a whole lifetime in between. But look, for the master's course, you have the option of either doing a thesis or spending 20 hours a week at a company that was relevant to your studies. And I went to a Cambridge-based company, Apt Associates, and I was attached to their health economics unit, and we did some of the most interesting modeling on medicine discovery and other parts of that. And I think the option there was to stay, get a green card. It was all part of that. But also possibly with the investment banking division of Merrill Lynch. Around that time, I think my old man was starting to be unwell. And we took the decision to come back. And I landed back on my feet consulting, but was mainly active in the medical scheme administrative industry. But during that time, I was COO of clinics, but also entrepreneurial venture on a pharmaceutical company, which was pharmaceutical marketing and sales company that we were bought out of, I think around 2015. But what I would say is that I achieved my goal of seeing healthcare from all aspects.
Yes.
And what that did is that when you talk about luck, I regard myself as someone who was very lucky if you define luck as preparedness meeting opportunity. I could never have planned to be a panelist on the health market inquiry. Which then when it was set up, I just knew that this is what I wanted to do, because there would be very few people who'd get the opportunity to see healthcare from the perspective that I was to see. So I was to spend the next 5.5 years. This was supposed to be a 2-year project. I was to spend the next 5.5 years as a panelist, during which time I was, for obvious reason, I was not allowed to earn anything from the health sector, not consulting, not a salary, not board, because it was
potential conflict.
So towards the end of this now, I said, okay, what am I going to do? And what I knew for sure was that I didn't want to go back to corporate. But the question in this crowded space, what was I going to do? And I think I decided to focus on new innovations in healthcare. Excuse me. And I was attracted to the emerging blockchain technology. So I studied that in detail. I spent own money to try and now see if this is really happening or it's just theory. I attended conferences in the United States. I attended the first ever blockchain policy conference in Paris. And I came back and basically I was asked to speak at Gibbs on I think the health market inquiry, but then I asked to also speak about blockchain in healthcare. And they gave me a 30-minute slot. I spoke, and I'm told that was well received. And again, I applied and asked to speak at Africa Blockchain Conference. I said to the organizers, we've got 33 speakers, all of whom are talking about blockchain for the fintech side or regulation, but healthcare is one of top 3 most amenable fields for blockchain. And I spoke, they asked me to come back the next year. So I started working, and in 2019 is the year I say was the first contract I signed for Alchemy Health Technologies.
Yes.
And a lot of work has happened in between. And it's a health data management company, because what we looked at, I said, look, if one looks at the whole health ecosystem, of course, there's a patient in the middle, but you have a very well-established funder industry in the sense of your medical scheme industry locally. And then we've got very good on the hospital side. Those are all corporates who know how to look after themselves. And of course, the pharmaceutical companies, the medical device companies, and then the regulators. So I said, but where is the opportunity? And then I said, I identified 2 important players within that ecosystem, and they are actually so obvious, but I felt that they are underserved. One being members of the general public or the patient.
Yes.
Patients are what healthcare is about, but they are the least informed about their medical conditions. They don't have access to their information, and really are not equipped to engage with the other health stakeholders on an equal footing.
Yes.
And so part of what Alchemy is about is to what I call patient empowerment, but is to help members of the public be informed and be better placed to engage with the health stakeholders who are established. And mind you, this helps the wellness aspect, which you are an expert of, and of course, really just treatment in terms of just making sure. So I think there is a gap that we are on course to start engaging. And funny enough, if there is one positive out of COVID, this is it.
Yes.
Members of the public are talking antibodies, are talking antigens. They know Pfizer, they know AstraZeneca. So the ground has never been more fertile for people to really meaningfully take charge of their health information, and we will be playing in that space. But also the other group, no one believes, it's the health practitioners.
Yes.
Health practitioners are very important for our business. They are important, but I do believe it is true that healthcare, that the internet bypassed the medical profession. We are addressing that now. But when we think of health technology and the medical profession, we think about the high-tech interventional stuff,
robotics,
keyhole surgery, the robotics, the MRI scans that are wonderful and all of that, but just running the business of healthcare. And because these are all business people, whether they want to be in business or not, they are. And what's missing is the control of their health notes. Notes are sitting somewhere in written form in cupboards. And if practitioners' information is not digitized, the entire industry is a loser, because there's this critical information that's not anywhere in the healthcare system. What we have, it's more what I call financial information in terms of claims and that have been paid. That's the best we have. So that is also one area that we will be looking at, and we have.
There's a serious shortage of data, population kind of data, You know,
Yes.
if you took all of this information from the individual practitioners, you know, and have a reserve of information, yes, there will be data from the studies that are being done, but that's limited. But if you want to say, you know, like the NHS would, you know, during the time of COVID, they can get information about what's happening across Britain, you know, in the first 3 months of COVID. And we would struggle to have that.
And where you have it, it's in silos.
Yes.
The general practitioner has the own information, but then the specialist doesn't necessarily see what the general practitioner has.
Yeah.
And I say, if, for example, you see a patient, you refer to a specialist, and the patient ends up having a hip replacement, total hip replacement. Now, the only entity that comes closest to having complete information is the medical scheme administrator. Because you will have a claim from the GP, a claim from the specialist, from the physio, from the hospital, in ICU, in theater, in general ward. But even then, that's financial information. That's what we need to sort of look at.
Yes, and I've actually seen in the past year, Discovery Health, you know, coming up with very critical information, for example, about the effectiveness of vaccines, because they could see the before and the after, you know, in terms of hospitalization, deaths, age groups, and all of those kind of things. And so having that global view can actually help to plan things better.
Absolutely, absolutely. That's exactly where, as a nation, we need to be aiming to get to, because it speaks to the other lessons from COVID, that the partnership between the public and private sector is just essential. But it's a long road, but one, it has to be said that it's being addressed. The issue is to say, what does Alchemy believe it can do to contribute? We're not so ambitious to believe that we have all the solutions.
You can't do everything, but you'll have to pick an area.
Pick an area and contribute to the bigger cause. So there is absolutely, we're excited about what we hope to contribute. And we've been working.
By the way, let me give you feedback that I'm loving your social media presence as Alchemy. You know, I really am loving it. You know, I think it's last 3 months, the stuff that is coming up there, whoever is assisting there is doing a great job. All right.
No, thank you. The team will be pleased to hear that. Thank you.
All right. So now, Doc, let's go back now to matters of national importance. Okay. The first one, you are in the National Planning Committee. Is it not?
Commission.
No. What do you call it now?
Commission. Commission, National Planning Commission.
National Planning Commission, you know, Vision 2030. Just tell us a little bit your contribution there, because there is about, you know, different people coming from different areas looking at the South Africa we wish for, or the South Africa we want. So from a healthcare point of view, what is the vision and what needs to be done? You know, from different angles. So you are one of the people there in the National Planning Commission. You've just been renewed your participation there. You know, so just tell us a little bit, as South Africans, just, you know, what the commission is all about and what you do specifically in trying to shape the future of healthcare in South Africa.
Yeah, no, thanks. The NPC is one of what I regard as my own contribution in terms of national service. What most people won't know is that I've only ever been employed by government on PESAL as an intern, and when I was doing training for anesthetics out of King Edward. But I have had 20 unbroken years doing work for government on an advisory capacity, and these are never for for the income.
Yes.
But the NPC is very strategic. What we are hoping to do is basically 27 people,
Yes.
who, not my word, but who are invited as individuals who are experts in their field. I say expert, it's not my word, it's what's in the advert that calls.
Yes. Yeah.
And it's also important to
I like your humility.
Yeah, but it's also important to say that we are invited as citizens.
Yes.
We're not representing any political party, any organization. We are just citizens and must provide research-based policy advice to cabinet via the minister in the presidency. Yes. The minister in the presidency is the only politician, because obviously that's the conduit that basically makes sure that our advice is at least delivered to cabinet. We work closely with the Department of Planning, Monitoring and Evaluation, who also provide the secretariat. Now there are about 26 and the minister, and all of us are different. We come from different fields. Some are business, the economy, issues regarding youth, issues regarding spatial planning, and I'm health. I'm the lead on health-related issues. And it's interesting because the first commission, this is our third now, the first commission put out the National Development Plan. And the second, which I was then part of course, part of the things we did was to start reviewing what's in the development plan, what do we believe is likely to be achieved, what is not. Of course, we've taken on board the criticism that came with it. The most common one being that, are we really impactful? Now, part of what we obviously need to do going forward is plan for that impact. We certainly have been impactful. A lot of people, when they start seeing the output that we have to show, they are surprised. Maybe what we didn't get right is to basically speak loudly in terms of what we're doing. I believe that will change. We do have a commissioner who's a specialist in communications and PR, in the form of Commissioner Nigwe Pigicha, who's well known. So I believe that that will help in starting to get the work out. But more than anything, we need to make sure that this is hard-coded into law, so that the national plans are not subject to whichever party is in government. This plan should be the plan for the country. Whoever is the governing party, we should all be walking lockstep in one direction. So we believe we'll progressively get better and be more visible.
Beautiful talk. One day I think we'll come and talk about that one deeper. But no, I think just for the benefit of the audience, I think that's sufficient to say there's a lot of work being done, by men and women, who are giving their time, because they believe in this country and the future of this country. Let's go back then to the other part. You became a panelist at the Competition Commission's,
Health Market Inquiry.
Health Market Inquiry, all right, under Judge Sandile Ngcobo, right?
Yes.
It was again supposed to be just like a year or two. It also took something like 4 years or so, all right? And my understanding, and please correct me, my understanding was that, there is this narrative that the private sector in South Africa has got all the solutions to the problems of healthcare in South Africa. And all you just need is to just get the private sector to take over the public health sector, and we have, a utopia of some kind.
Yes.
So, and yet, quite a number of people believe that, there's a lot of challenges in that space, and they believed before you guys went to actually investigate.
Yes.
Now, so you guys came up with your first draft, and then it allowed for stakeholders to give feedback.
Yes.
And then you guys came up with your final, report. At a high level, Doc, what was found at a high level, just the key findings? We won't go deep in each,
yes.
But is it the panacea that we've been made to believe it is for the future of South Africa, or actually it's got its own unique challenges? It's not as healthy as it was made to believe, as we were made to believe.
No, certainly you're absolutely right, because in the Competition Commission deciding to set up the health market inquiry was based on issues that didn't seem right. But the point is, there really was no quantified explanations in terms of what was wrong. So that was the starting point. They did preliminary analysis and then appointed a 5-member panel. And the point is that what we found, I think it's important to basically say, to look at the structure of the health sector. As I said, there are financiers, people or organizations that fund healthcare.
Hospital groups.
And then there's also the practitioners and hospital groups on the delivery side. We did not look at the other arm, which was the product side, the pharmaceutical companies and medical devices, mainly because it was felt that the expenditure had come under control with the single exit price legislation. Yeah. So what we found really is that on the hospital side, it was highly concentrated with only a few players, 3 hospital group, Life, Mediclinic, and Netcare, having in excess of 80% market share. And we still on the hospitals, we found that hospitals actually do not compete for patients. They compete to get the doctors, especially specialists. They compete to find the best. And in there were potential problems in terms of how that's done and whether the laws... Perverse incentives, or whether laws were at risk of being breached in that regard. But those, I think, were the main ones. The really important part about concentration, where you have such few players holding such high market shares, is that research shows the quality of care is never as good as it can be.
Yeah.
Price is not as low as it also can be. So those are the direct outcomes where you don't have many players in the market.
Yeah. So now, what they call a oligopoly.
Yes, and what we found exactly as well in the funder side of things is exactly the same, where Discovery, MedScheme, and Metropolitan groups also were managing more than 75% of people in the medical scheme type of business. We had concern about the governance of the medical scheme industry. Yeah. But what everyone on medical scheme will know is that we found that the complexity of medical scheme benefits, it's so high. I mean, I've been in this industry all my life. I still don't quite understand my plan. And the worry there is that if you do not simplify it, then you are actually reducing competition between the players, because you can't really compare like for like for different plans. And then practitioners, we found that there's really little regulation that's there once they are qualified. The pricing is uncertain. Your viewers here will tell you that this is one industry when you are consulting, you actually don't know how much you're going to pay. It's unique. It's a problem. We looked at it and came up with recommendations, but of course the regulators still haven't moved. There's no innovation, largely driven by the rules of the Health Professions Council in terms of how we provide service. And then, of course, consumers themselves are not free of guilt, even though they're disempowered and maybe not as informed as they are when choosing a television set. But we found this anti-selection in the sense that if you are you are the one who best knows your medical condition. So there's an element of waiting and not joining a medical scheme until you know that you are about to start using medical schemes, either because you are planning to be pregnant or you know that I'm getting old now. As I get older, I'm likely to be sick. So there is, and then we had problems with regulators. So we like that there isn't anyone we believe that is actually the ultimate complement, that we actually do what is required. And that is why it's regarded as the most far-reaching policy review this country has seen
ever conducted
in healthcare since 1994.
Yes, but there's something that I also, it actually forced me to think, Doc, the fact that the transaction between a practitioner and a patient, in a normal, situation outside of healthcare, if you want to buy a product, you can ask about that product, specifications, everything, and be able to decide whether this is value for money or not. But when it came to matters of health, the patient is most often at a point where they have to pay, but they don't really understand, why, so the fact that there could be incentives at a doctor level to decide on option 1 versus option 2, because there's certain benefits, and the patient may not be in a position to say, okay, if there's a gallbladder that needs to be removed, do I go open surgery? Do I go, the laparoscopic one, and all of those kind of things? So the fact that the transaction in healthcare is not a transaction of equals from an information point of view. Just a little bit about that, because you guys did raise that.
Yes, it's absolutely true. What I want to start by saying that it's obviously not a South African problem. This is a global healthcare issue that has been studied in detail in health economics. And it's the concept called asymmetry of information, meaning just by design, you are at a disadvantage as a patient simply because you just aren't trained to understand medicine to the extent that the person who's examining you understands it. So that issue does places the patient at a disadvantage. But funny enough, we also did find a different but related concept in the sense of supplied-induced demand, which is what you are referring to, where the one person who's your agent, which is your practitioner here. This is your agent. This is the one who's helping you. This is the one who knows the field. Also is the one who decides what must happen. But the unique thing is that that decision is directly linked to how much he or she is going to earn. And we did find an example of this supply-induced demand in basically some of the decisions where a decision, for example, to admit was made when it wasn't necessary, for example, where the more expensive option is chosen when a sort of less expensive one could have done. But it's not such a straightforward issue because we are in a highly litigious environment. So you also have to understand when practitioners say, you know what, I think you have pneumonia, but you know what, if I miss something else, I'm going to be sued. So let me just order this X-ray just to make sure. Now I'm using X-rays, not so expensive, but obviously over time, the volumes, it does show. But also, again, we've got patients who choose to go, I've got a headache and they want to go see a neurologist or even neurosurgeon.
Yeah.
That adds up in terms of cost. So but it was quite comprehensive in terms of what we did. Yes.
Yeah. Just the last one on this issue, because now I want us to talk NHI as we go towards wrapping up. Yeah. Yes. So you guys brought some interesting perspectives from the OECD. Where they were comparing in general cost of healthcare delivery in South Africa in relation to the benchmark in the world, and they objectively provided proof that basically the cost of healthcare in South Africa is exorbitant.
Yeah. Yes. No, that's absolutely true. They were able to show, obviously looking mainly in Europe. Well, some of the defenses that the industry put, for example, were saying, well, you're actually comparing private sector locally with government provided services in Europe. In Europe, most countries are really on the universal health of some sort, where the government is the lead purchaser and provider of healthcare. So there were fights around that, but certainly you could not ignore that South Africa, being a middle-income country, but our spend on healthcare compares with the likes of the Germanys or whatever.
Yes.
But also the other point, of course, was exactly that whatever we say, one thing that our public sector can't show is the real cost of providing healthcare in the public sector. We do not have sort of studies. It's easy to quantify that from the private sector perspective, but there is no information that tells us if you are in a surgical ward at Chris Hani Baragwanath Hospital, what is the real cost to the public sector?
Yeah.
That obviously could have helped in terms of being far more certain regarding the comparisons, but without a doubt, it was a very important point that was brought through by the OECD.
Beautiful, beautiful. Just, as we're getting to the NHI now, or at least let me not say NHI, let me just say universal healthcare, because I think that's the generic term. So the fact that as South Africa, we are actually spending reasonably enough for healthcare, right? About 8.5 or so of our GDP, comparative to most countries. I'm talking about developed countries. Germany, you've mentioned it. The only countries that spend more as a percentage of GDP than us are more the Scandinavians.
The US.
Yes, and the US. So therefore, the question then is, and you get to be told that about 55% of our national spend on healthcare, somewhere around 50 to 55%, is actually going towards about 17% of the population. That is the private sector.
Yes.
And the 83% is covered by somewhere around 45% or so. I mean, that situation, it's not sustainable. So when people are actually, arguing for things to continue as the same in the private sector, and you've already mentioned, from the HMI, the issue of cost of private sector, so I think as a country, we've got challenges on the public health sector side, we've got challenges on the private health. Both of them are not sustainable as is.
Absolutely.
Which means universal healthcare. Let's talk about universal healthcare. You first got the taste of that with the NHS in the UK.
Yes.
And you then studied public, MPH in Harvard, and you were exposed to more.
Yes.
So just tell us a little bit. If I was a South African who still has doubts about this NHI, I'll put it as NHI, but that's the word we use here.
Yes.
Yes, universal healthcare. Can you put a case for universal healthcare in South Africa?
Now, I certainly, without a shadow of doubt, I'm for universal health coverage in South Africa, because at its foundation it's really about saying people should get access to healthcare to the extent that they need it. It must not be based, whether or not they get it must not be based on whether they can afford healthcare. So this is where the principle of cross-subsidization comes in at the level of the healthy subsidizing the sick, if you like. The other point here is that no one should go bankrupt trying to get treatment. And you only have to look at the US. Every single year, hundreds of thousands of people go bankrupt for healthcare services.
Yes.
It's just not right. It's not fair. It shouldn't be. Then the other point is to make sure that the service that is provided must be of sufficient quality. And in terms of then how do you get to these goals? It's about basically saying everyone who's got means must contribute towards this universal coverage.
Yeah.
Everyone who has got means must contribute.
Yes.
Then the next level is that there must be pooling of these resources.
Yes.
Now that's where the insurance part comes in the sense that it's subsidization. Those who are wealthy will subsidize those who are poor, and those who are sick will be subsidized by those who are healthy.
Yes.
And then the task falls on the government for the other important arm, in that the strategic purchasing is an important part. And if you imagine, if you're talking about this animal that in 2019 terms is about 400 billion, certainly far more now. If you have one party, I don't mean political party, I mean one entity that is tasked with purchasing care for all of those who need it, then you should be in a position, if you're doing it properly, you should be able to get services without compromising quality, but also reasonably cost effectively. Bearing in mind, though, that no country can afford all the health services its citizen needs. So there will be an unavoidable element of rationing.
Yes.
It certainly must happen in realization of that Constitution, Section 27.
Yes.
It's important. The issue becomes whether we've got the capacity to undertake this largest project that this country has seen in the in the few decades. Do we ignore what are we doing to deal with the corruption? What are we doing regarding just rank incompetence, which is inevitable if people are not appointed for competence? That also becomes an important issue. But the principle, certainly, I do not think anyone who's fair can argue with the principles of universal health coverage.
Beautiful, beautiful talk, beautiful. And by the way, it's not like a ANC government thing. The WHO member countries resolved that by 2030, every country should have a universal healthcare system.
Yes.
And those who are in doubt should look at how the countries with a universal health system have fared better in terms of delivery of healthcare and the cost thereof during this time of COVID than countries that don't. You know, the question then that I ask you, because this thing was supposed to be rolled out from 2026. Now we've had COVID. It has messed up, the financial, the PES, the government PES. Do you think we should still go ahead? Or do you think we should be waiting until the finances improve? Just your thoughts, just high level.
Yeah, my view, Bele, is that the issue of universal health coverage must be seen as not a destination, but a direction. Meaning we need to start. There are parts where we can start.
Incremental.
For the simple reason, the point I've already made, no country can afford all of the services its citizens can consume. So we'll never get to a stage where we say, we now have enough money to sort of implement this. I think, I can't remember whether it was Qatar that gave its government, say, we give you 2 years to implement universal coverage. How much does it cost? Not all countries can do that. So the point of making sure, but I also use the other example in saying those who say no, don't start NHI until we have got the money for it. I always use the example of SANRAL, our roads agency. SANRAL has got a beautiful interchange in Mount Edgecombe, Mhlanga area. That's important. But the equivalence of that, in my view, is that SANRAL must not come up with such developments that are important for the economy until every gravel road in all of the villages and rural areas have been tarred. I don't think that's the argument we should have. There are principles. It's about planning properly. It's about knowing where the low-hanging fruit are, but also taking advantage of the private sector, because the private sector is an asset of the country. The main point of stress is that this does not mean that anyone must escape contributing towards the NHI. Everybody must. And we have to learn from COVID, where people who don't have medical aid, but when they needed the most intensive ICU treatment, they were at your Netcare hospitals, your clinics, your Life Mediclinic or Busamed, simply because the need was that they must get care and not so much whether they can afford normally to be at a private hospital. We must learn from how the vaccines have been managed. We must see how the industry came up with the Solidarity Fund when we were all scrambling and private sector says we are pledging so much while we are all still finding our feet, but we secure PPE supplies.
Yes,
now,
ventilators.
The point is to learn how these two entities or these two sectors can work together for the benefit of the patient.
Beautiful, Beautiful, beautiful. So from your vantage point, Doc, this is my last question. How do you, from your vantage point, having looked at what COVID has done in our country, and the need for universal healthcare, if you had to, anyway, you are part of the NPC, you whisper to the cabinet about, the future of our healthcare. What would be the three things that you'd say? If you do 1, 2, 3, we will change the course. Obviously, it's a journey. It's not something achieved overnight.
The issue of starting with the planning, it has to happen, but there must be real efforts regarding the one big hole in the plan, and that is about the funding model, because that's important to get there quickly. I would certainly try and make sure that we all understand that healthcare cannot really be left only to the health sector.
Yes.
It's far too important for it. And this is exactly what we talk about. And COVID reminded us that big parts of our problems are really logistical problems. And logistics cuts across all industries. So again, this is what policy wonks have been saying throughout the years, that healthcare is equal to the economy. And this has been said many times, but has been ignored until business is now finding itself having to shut down, having to take responsibility of their employees and their customers. We can't go back from that, in my view. The time has passed for business to really just think about medical aid when they think about doing something about healthcare.
Yeah.
Most people who are employed still don't have health insurance. So it's a question of all hands on deck, and it's about needing to enable that. And we all have to play a role. And it starts with the patients and members of the public to understand their health situation and what they need to do.
Yeah, thanks, Doc. I think at this point, I need to just thank you, Doc, for the time you've spent. Initially we were supposed to be just 60 minutes. And I said, well, maybe we'll go to about 90. But there's just a few comments that came from our Facebook line. From Sizagele Murugu, as she was listening, she sent a message to say, that was me, but I'm not sure which part, that was me. And then there is Ntokozo Nomaswazi Mzimela, who said, it's truly inspiring, Doc. Thank you so much. The information you shared, the journey that you've traveled. My younger brother, Langa, who is in Umtata, he says, I'm enjoying this interview. Thank you for featuring Dr. Bhengu. And your colleague, and I'm not sure if I think she was your classmate, but Nandi Pakasha.
Yes.
Dr. Nandi Pakasha, yes. Interesting interview. I've always wanted to be in healthcare management, and I had my first opportunity 5 years ago in COID. I'm not where I aspire to be yet. I will hook up with Dr. Bhengu for guidance. All right. Then she further goes on to say, I'll assume Dr. Bhengu has been involved in laying groundwork for NHI by virtue of him being in the M&E and chairing or leading rather, as a lead in healthcare in that commission. Can you please share the progress on NHI pilot sites and how far we are as a country from rolling NHI? I think that question needs to be asked more from the National Department of Health. Because it's one thing that Dr. Motsoaledi just navigated around and dribbled us, was we were all looking forward to hearing the outcomes of the pilot sites, the 12 districts that were chosen as pilot sites. And the issue of the funding models, you're saying she's interested in knowing the funding model and feasibility. All right, so I think this is something that we may pose to the National Department of Health, Dr. Joe Patla, or Nicholas Crisp in the near future, but I think not for this interview. So, yes. Doc, but I need to just say thank you. There's never enough time to be able to cover these things. But what I wanted to do was to honor you, to recognize you for the work, excellent work that you are doing, helping to shape the future of healthcare in South Africa for all of us. Yes. Obviously, working with other people, but your contribution is very, very, very important. But also to show younger people who may be doctors or wanting to be in medicine that it's not only about being in clinical, medicine. There are other avenues that are less explored that are actually as important to make sure that the future of our healthcare is actually, in the right hands. So you are an example, of that. For that, I once again, I just want to say thank you, and may you continue to do what you are doing. And for Alchemy Health Technologies, your baby, the new technologies, the blockchains and other things that you guys are doing, data mining for this and that to solve some of our big problems. I just want to wish you guys well. That's what we need. We need more entrepreneurial ventures that are not going to wait for government, but sometimes we'll come in and try and provide solutions where they can and collaborate with others where they can't. Yes. So with those words, Doc, I just want to say thank you very much. And for people who logged in, it's been a longish interview, but I think it's a very important interview. We hardly have, you are the first person who comes from that angle of healthcare management and leadership. I haven't even had time to talk to you about matters of governance because you are the chartered director. People need to know what a chartered director is. It's a new space, that we need to exploit to ensure better governance of organizations in South Africa. But we'll have time to talk about that on another time. So thank you, and thank you to everybody. May you have the rest of your Sunday being a restful and productive one, and a good week ahead for everybody.
Yes. No, thank you very much, Pele. Yes, I do know Nandip. I think she was a few years behind me, but I certainly know her and always ready to comment, to help where I can. I think Alchemy will be as I said, practitioners as well are important to us. Sizakele Moloku is my sister. When she says that is me, it must be the part where I said, my father got his matric at the same time as one of my sisters. But certainly to thank you, Pele. I mean, you've been very kind for inviting me. Your words are certainly highly appreciated, especially since they come from a respected industry veteran that you are. And at any time, I'm always available when it suits you. But thank you very much. You're doing a fantastic job with these interviews, and I appreciate the chance to be here.
Thank you very much, Nolosi. Thank you. Until we meet again. I know we will have our offline meeting about other things on collaborations. But for now, thank you very much, and we will pick that up offline. Thank you, Doc.
Thanks, Ben. Bye.
All right. Thank you.